Welcome everyone. Welcome to the Let's Crack NEET PG channel. I'm your pharmacology educator, Dr. Arpit Agarwal, and I welcome you to the part 3 of our pharmacology session of side effects of drugs. So this is the third episode in our side effects of the drug series brought to you by the Let's Crack NEET PG channel of the Unacademy. Unacademy is the best learning app, so download the Unacademy and help us crack the NEET PG with you. About myself, I am Dr. Arpit Agarwal, MD in Pharmacology, and I have been teaching pharmacology to students for the last 10 years. Over all these years, I have mentored more than 50,000 students preparing for both pre-PG as well as for the FMG examination. Unacademy app, if you have not yet downloaded, you can download it from the iStore or the Play Store. Download it right away. Unacademy brings you two options, either the Plus subscription or the Iconic subscription. With the Plus subscription, you will get the unlimited live classes with the best educators of the country. Also, you'll get the live tests and quizzes, batch courses. With the Iconic subscription, you'll get the best of Unacademy and Preparator. So with Unacademy comes the unlimited access to the live classes, live tests and batch courses. With the Preparator, you get the recorded video lectures along with the question bank, revision notes and the handwritten notes. So that is Iconic subscription for you, which gives you best of both the worlds, Unacademy and Preparator. Two kind of subscriptions are available for NEET PG as well as the FMG, the Iconic as well as the Plus. If you use the code Dr. Arpit Agarwal, if you use this code, you will be able to get a 10% discount on your overall subscription fee. So Iconic subscription can be availed for 12 months, 18 months, 24 or 36 months. Using the code Dr. Arpit Agarwal gives you a 10% discount on the total subscription fee. You can also go for the Plus subscription of the Unacademy for a duration that suits you the most, ranging from 1 month to as long as 36 months. Again, using the code Dr. Arpit Agarwal. If you use this code, remember this code, it will give you a straight 10% discount. Straight 10% discount using the code Dr. Arpit Agarwal on both Plus as well as the Iconic subscription. Unacademy brings you the best of educators across the country for all the subjects to help you crack NEET PG. Unacademy also provides the new batches every week by the top educators, and the batches are designed keeping in mind the needs of FMG students, NEET PG students, as well as those students who are going to appear in the next 2020. So subscribe to Unacademy now. It is the best learning app in the market. Starting with today's session of the side effects of the drugs, today we are going to discuss the important side effects of the CNS drugs. Okay, important side effects of drugs from CNS, very, very important. In our previous session, yesterday we discussed the important side effects of the anti-cancer drugs, and today is the day for CNS drugs. So first question on your screen, acute intermittent porphyria, very, very important. Porphyria is precipitated by which of the following drugs? So simple direct questions are very common, especially when it comes to the side effects. So porphyria is precipitated by which of the following drugs? Your options include ketamine, alcohol, barbiturates or all of the above. Now how to remember this question? How to attempt this question? You have to remember the drugs causing porphyria. And the important drugs causing porphyria can be remembered by this simple mnemonic. So you write porphyria as it is. Okay. The mnemonic is porphyria itself. So the mnemonic itself is very simple. All you have to remember is porphyria. Porphyria. Let's see what each of these letters stand for. Let's see what each of these letters stand for, and then you will be able to easily attempt this particular question. So P stands for an enzyme inducer. P stands for enzyme inducer by the name phenobarbitone. or barbiturates. So phenobarbital or barbiturates, they are important cause of precipitating porphyria. So barbiturates can cause porphyria. What happens? They will increase the activity of the enzyme ALA synthetase. They will induce the activity of enzyme ALA synthetase, which is the rate limiting enzyme of porphyrin synthesis. So ALA synthetase will be induced, it will form more porphyrins and you will have porphyria precipitated. O stands for OCP and OCP actually means estrogen. So estrogen are known to cause porphyria, so remember OCP. R is again an enzyme inducer in the form of rifampicin. P is again an enzyme inducer in the form of antiepileptic phenytoin. So they have the same logic as barbiturates inducing the ALA synthetase. H is an antihypertensive drug, hydralazine. Y, to make the mnemonic complete, we have to be slightly imaginative. Y stands for yelproate. Now, there is no such drug as yelproate, so actually it refers to valproate. So yelproate, I hope you can remember yelproate, valproate, it's the same thing. Then porphyria, here you can remember R stands for reserpine, that can also precipitate porphyria. I stands for IV anesthetic, very important, IV anesthetic such as ketamine. So ketamine is an important cause of porphyria. And A stands for alcohol. So alcohol is also important cause of porphyria. So answer to this question will be all of the above. A also can stand for antibiotic. Such as one important class of drugs known as sulfonamides. Okay, sulfonamides are important drugs precipitating porphyria. A for alcohol, A for antibiotic. So remember this mnemonic porphyria. It will help you remember the important drugs precipitating porphyria. Out of so many drugs which are important, ketamine is a very important cause. So is alcohol. So is sulfa drugs. Then OCP or estrogen are very important. So these options you will find commonly in the MCQ. So remember drugs causing porphyria, very important topic. Mostly the presenting complaint is sudden onset of severe abdominal pain. Sudden onset of severe abdominal pain should raise in your mind a suspicion of drug-induced porphyria. Next question. Which of the following causes pseudoporphyria? So now that you know porphyria, the examiner sometimes is very naughty and he just wants to test your knowledge of fancy side effects, pseudoporphyria. So can anyone let me know which of these causes pseudoporphyria? Any one of you? Which of the following causes pseudoporphyria? Now you see Sunshine, Avinash, you are getting confused. Pseudoporphyria and pseudo jaundice. You have got confused. Answer here is neproxy. So that is what I meant when I said examiner gets naughty. He asks so many pseudo. So one of pseudo is pseudoporphyria. Answer is what? Neproxy. Now what is pseudoporphyria? I have this slide to help you understand. You see these bullous lesions? It is a bullous photosensitivity that mimics porphyria, but it has got no increased level of porphyria. So it is a pseudoporphyria. The clinical situation resembles porphyria like lesions. No abnormality of porphyrin, as I told you. Mostly it is done by ultraviolet light exposure, so it's a photosensitivity. And the drug that commonly causes it is neproxy. Clear? Pseudoporphyria. Understood? What mistake you can commit? Pseudoporphyria. So porphyria, when you are discussing, anytime you are studying porphyria, never forget to remember pseudoporphyria. Clear? I hope now you remember pseudoporphyria, a condition that resembles porphyria cutanea tarda, bullous lesion, but actually it is a photosensitivity. Naproxen is one drug that you have to remember. So clear? Avinash, and Murli and Sunshine. Understood? Now, why did you say rifabutin? I hope now you can understand which of the following causes pseudo jaundice. Pseudo jaundice. Understood? Pseudo jaundice is now the next question. What is pseudo jaundice? I have mentioned it is yellow skin, but there is no bilirubin high. Okay, it is simply a yellowish discoloration of the skin without any jaundice, actual jaundice. So now the answer will be rifabutin. Now the answer will be rifabutin. So understood the importance of the word pseudo. Okay, pseudo as far as the drug side effect is concerned. So one we have discussed pseudo porphyria, naproxen or NSAID can cause pseudo jaundice, rifabutin. Rifabutin. Clear? Now it is rifabutin. Okay, rifabutin. Next, since we are discussing pseudo, so then why not go to other pseudos? Pseudolithiasis of bile. You see pseudolithiasis of bile, which can cause pseudolithiasis, so pseudo porphyria, pseudo jaundice, pseudolithiasis of bile. Now, what is your answer? Pyroxicam, rifabutin, phenytoin, ceftriaxone. Rifabutin is not going to be the answer because we have already discussed what pseudo comes with it. Okay. Now the answer is ceftriaxone. So what you have to remember here? Ceftriaxone is eliminated in bile. Okay, it is having bile elimination, and that is why the drug is believed to be safe in renal failure. So normally you get this question that which cephalosporins are safe in renal failure? You mark ceftriaxone or maybe cefoperazone. So normally you get this question. So what we understand that ceftriaxone is going out in bile. It is excreted in bile. So sometimes what can happen? It can precipitate in bile. It can precipitate in bile and lead to stones, but they are not cholesterol stones. It is ceftriaxone precipitation, and that is known as pseudolithiasis of bile. Pseudolithiasis of bile. You stop the drug, this condition will go away. So ceftriaxone. So understood how a clinically very important point that antibiotic which is safe in renal failure, commonly asked question, safe in renal failure, how the same question can be asked in a very different manner also, clear? Pseudolithiasis of bile. Next question. Which of the following causes pseudo-lymphoma? So we are not giving up on pseudo. Now we have pseudo-lymphoma. Again, your options are the same. Pyroxicam or naproxen. We have discussed which pseudo was there. NSAID, pseudo-porphyria. With rifabutin, we have discussed the pseudo of jaundice. With ceftriaxone, we have discussed pseudo of lithiasis. So what is remaining? Phenytoin. Phenytoin is what is going to be the answer to this question. Phenytoin basically causes lymphadenopathy. Phenytoin causes lymphadenopathy. And sometime a wrong diagnosis is made as lymphoma, so that is known as pseudolymphoma. The condition is phenytoin induced lymphadenopathy in the patient, but a wrong diagnosis can be made that the patient is having lymphoma, and that is referred to as pseudolymphoma. Okay, pseudolymphoma, phenytoin is the answer. So I hope now everybody is clear. Everybody is clear on these aspects. That is naproxen causing pseudoporphyria, rifabutin causing pseudojaundice, phenytoin causing pseudolymphoma, and pseudolithiasis caused by ceftriaxone. Clear? All pseudo combined, and that is how you have to study. Whenever you come across these fancy terms, you have to write them at a common place and revise just before going to the exam. Okay? These are high yield questions. Okay? These are high yield points. Now, since the last question that we discussed was about phenytoin, so whenever we talk of phenytoin, how can we exclude the question on the side effect of phenytoin? Okay, so adverse effects of phenytoin include the following except. Your options include glycosuria, microcytic anemia, coarsening of facial features, and hypocalcemia. Difficult options are given deliberately. Deliberately difficult options are given to help you understand some of the finer points about phenytoin side effect. Prabhakar says B. Prabhakar says B, that is glycosuria. What about others? What do others say? Akshay also says B. Sayantan also says B. So then it has to be B. If so many people are saying B, so it is microcytic anemia. This is the answer. Why? Because phenytoin causes what we call as megaloblastic. Phenytoin causes megaloblastic anemia. Megaloblastic anemia with increase in mean corpuscular volume. Mean corpuscular volume due to its antifolate action. So that is the answer. But what about the others? What about the others? So let's see side effects of phenytoin in detail. Let's see the side effects of phenytoin in detail. What are the side effects of phenytoin? They can be remembered by the simple mnemonic phenytoin itself. Okay, phenytoin itself. They can be remembered by phenytoin, phenytoin itself. P refers to pseudo lymphoma that we have discussed. Pseudo lymphoma. H refers to hirsutism, or H also can refers to hypertrophy. Hypertrophy of what? Hypertrophy of gums. Hypertrophy of gums, which is believed to be the most common side effect of phenytoin. Now then we have EN. EN is anemia. Now there is no such term as anemia, so actually it is anemia. Anemia, EN, just to complete the mnemonic, anemia, and that is megaloblastic as I've told, because phenytoin has antifolate action. Okay, this question is also asked. Antifolate action leads to megaloblastic anemia. Why? Why refers to young female. Now that is not a side effect, but avoid phenytoin in young females. Avoid phenytoin in young females because it causes, as the question says, coarsening of facial features. Coarsening of facial features. There can be hirsutism, there can be acne and distortion or coarsening of facial features. So avoid phenytoin in young females. T stands for the teratogenic effect of phenytoin. Teratogenicity. So you all know fetal Phenytoin syndrome. Okay, commonly written as fetal Phenytoin syndrome. Now please remember, in fetal Phenytoin syndrome, what presentation will be given to you? What will be the presentation? So you will have, you see, mid-facial abnormality. So number one, you will be given facial abnormality. So there can be cleft lip or cleft plate, or there can be long philanthrum. Okay, mid-facial abnormality. And then you will have digital abnormality. Digital abnormality. Digital here does not refer to computer, it refers to digits. So fingers of the child or the infant are not properly formed. So facial abnormality and digital abnormality is characteristic of phenytoin or fetal Phenytoin syndrome. O refers to, now see, O is very important. O refers to osteomalacia. Osteomalacia, please remember, may result in what we call as hypocalcemia, may cause hypocalcemia and elevation of alkaline phosphatase. So please remember, sometimes they write osteomalacia, sometimes they write hypocalcemia as was given in the question, and also elevation of alkaline phosphatase is possible in phenytoin. In, if in is asked, last two, you will write inhibition. Inhibition of release. Now this is very, very important. Inhibition of release will occur of two hormones. One is insulin. One is insulin that would result in hyperglycemia, and glycosuria. And glycosuria was given as option A in your present question. So inhibition of insulin release, hyperglycemia occurs and glycosuria. And inhibition, please remember, can also occur of ADH release. So ADH release can also be inhibited by phenytoin and that would result in polyuria. That can result in polyuria. So please remember some of the rare side effects of phenytoin which can be presented are hyperglycemia and polyuria. They can occur. Some of things like alkylation of alkaline phosphatase, that is also given, and megaloblastic anemia due to antifolate nature can also be asked. So these are some points which are not commonly emphasized, and in this kind of question, in the question that was presented to you, if you see the other options, glycosuria is not very common side effect, but you have to remember hyperglycemia resulting in glycosuria. Similarly, hypocalcemia is not a very commonly asked side effect of phenytoin, but as I told, osteomalacia leading to hypocalcemia and elevation of alkaline phosphatase. So I hope now these rare but potentially confusing side effects of phenytoin you will be able to remember by the mnemonic itself, phenytoin. Next, now the question is asking side effect of phenytoin when its level is above therapeutic level. So what is the therapeutic level and which side effects occur on therapeutic level and which side effect occur on above therapeutic level? So you see the therapeutic level in blood, the concentration that we need for therapeutic action is 10 to 20 microgram per ml. Understood? Number one. This is the therapeutic level and it will lead to many side effects which I have told you in the previous question, remembered by the mnemonic phenytoin itself. So all the side effects that we discussed appear at therapeutic level. At normal plasma level, you will have all these side effects. So that is what was discussed in the previous question. Okay, in the previous question. Now, if the level goes above 20, okay, if the level goes above 20, then the side effects that appear are characteristic of phenytoin toxicity, and these are mostly neurotoxicity. So ataxia is one of the earliest side effect, followed by nystagmus. So ataxia and nystagmus is the commonest problem. So ataxia is the answer here. Look for neurotoxicity. If you give too much phenytoin, especially IV phenytoin, then arrhythmia, hypotension. These are other problems, but basically the question will always ask in phenytoin toxicity or at high plasma concentration about the neurotoxicity, that is ataxia, nystagmus or other cerebellar symptoms. So remember the side effects at normal plasma level, and for that you need to remember the plasma level itself, 10 to 20 microgram per ml. For no other anti-epileptic you will be not asked therapeutic level or plasma level. Only for phenytoin this therapeutic level is asked, and that is why you have to remember it 10 to 20 microgram per ml. Okay, so that is the importance of ataxia and nystagmus in a case of phenytoin. Okay, the moment this happens, that means you have given too much dose and phenytoin toxicity has occurred. Next question. This is a NEET question. Lithium was given for bipolar disorder. No problem with that. Which symptom should the nurse look for? So you have warned the nurse that if any of the following side effects appear, alert me immediately. So what are those side effects? So again, Prabhakar, Sayanta, Akshay all have answered correctly. It is ataxia, tinnitus, neurotoxicity. So this is a very, very important question, and let's try to understand this question in its entirety. So you see, there are many side effects of lithium. Okay, lithium also causes many side effects. The drug has narrow therapeutic index. The normal level for acute mania is between 1 to 1.5 milliequivalent per liter. For acute case of mania, this is the level. This is the level. Now in this level, what side effect normally we expect? Fine tremor, no problem. They are the normal side effect. You will do only symptomatic treatment. You can have nephrogenic diabetes insipidus, decreased ADH action resulting in polyuria, polydipsia. You can have decreased cardiac conduction, decreased cardiac conduction. So you will see ECG abnormalities, sixth sinus syndrome can occur. You will have what we call as thyroid problem. So hypothyroidism can occur because of decreased hormone release, and you can also expect the teratogenicity if given to pregnancy. So never give in pregnancy. Never give in pregnancy. These are some common problems weight gain, along with weight gain that are likely to occur during normal therapeutic levels. But if the level go above 1.5, the moment level go above 1.5 milliequivalent per liter, then you see the tremor will convert into coarse tremor. So that is not given in the options, but that is a very, very important sign of lithium toxicity, coarse tremor. Along with that, ataxia will start occurring. Along with that, this is also very clinically important sign, hyperreflexia. So patellar reflex will become exaggerated. Okay, exaggerated patellar reflex and profuse diarrhea. These are some of the problems that will be manifested mainly at very high or higher than normal plasma levels. So you have given lithium to a bipolar patient who is admitted in psychiatry ward. If normal side effects appear, you will have to do symptomatic treatment. There is nothing you can do. You cannot prevent these side effects. But if coarse tremor, ataxia as a symptom appear, or on examination hyperreflexia as a sign appear, then it means you have given too much of lithium and you need to reduce the dose. Sayantan says leukocytosis. Yes, Sayantan, increased in WBC count or leukocytosis can also occur in normal level, but that is generally not very dangerous. So, and it is actually not a sign, it is a symptom that you will find. It is not a symptom, it's something that you will find on laboratory investigation. So this has to be remembered. Phenytoin and lithium. What is asked nowadays? It is high chance that the side effects related to high plasma concentration may be asked, and you need to understand firstly the normal plasma level, and then what is the difference between a therapeutic level side effect versus a toxic level side effect. So the question is basically asking if you have the knowledge of the normal side effects versus the toxicity. Next question. Staying with the CNS drug, now we have S-citalopram, which I hope everybody knows, SSRI. SSRI, very commonly asked side effect, which is not an adverse effect of S-citalopram. Not a side effect of S-citalopram. So now, when you are asked SSRI side effect, mainly there are two problems that are asked. Mainly, number one, most common problems are GIT side effect. Okay, GIT side effects are most common problem, and they are usually, the question that is asked is about diarrhea. Okay, diarrhea, most common side effect. Okay, most common. But another very interesting, most common in long run. You see, diarrhea, nausea, vomiting. The GI side effect, patient will develop tolerance in due course of time. In long run, most common side effect become sexual side effect. Now this is very important. Sexual side effect. Increase in serotonin. Increase in serotonin in spinal cord causes sexual side effects. So you will have decreased libido. That makes it troublesome for young males. Secondly, you will have delayed or absent orgasm. Delayed or decreased or absent orgasm. So that is another problem which will appear. So these are the side effects which normally are asked. GIT side effects, so nausea will occur and orgasm or delayed orgasm is possible. Then the third side effects which are not very common but may appear are CNS side effects of SSRI. And CNS side effects generally include sleep disturbances. Sleep is disturbed. It can be insomnia, नींद नहीं आती है, या फिर vivid dreams. Vivid dreams. Vivid dreams. So vivid dreams can also occur. So then which is not an adverse effect? Cialorrhea is not an adverse effect. Cialorrhea is seen with clozapine. Okay, clozapine antipsychotic drug. So everybody has answered correctly. So sexual side effects. Sexual side effects are the one on which mostly the question is asked. So since it is a very important topic, let's discuss some of the other questions asked about sexual side effect. Which SSRI will cause maximum sexual side effect? Maximum sexual side effect will occur with which SSRI? Which SSRI will cause maximum sexual side effect? This is again fact-based question. You have to just remember maximum sexual side effect will be caused by which SSRI? Tell me, which SSRI will cause maximum sexual side effect? Paroxetine, correct. Prabhakar, correct. Paroxetine, correct. Then the question is asked, antidepressants with minimal. Prabhakar will come to a question, minimal sexual side effects. This question is becoming very important. Which antidepressants will cause minimal? Which class of antidepressant will cause minimal sexual side effect? Two antidepressants you have to name. Minimal sexual side effects will appear with which class of antidepressant? Which class of antidepressant will cause minimal sexual side effects? So if patient is not willing to take SSRI, we can give him minimal में number 1 आएगी mirtazapine and next will be, if mirtazapine is not provided in the option, bupropion. Okay, bupropion. Clear? Okay. So that is about the side effects of escitalopram. Prabhakar, again you have committed the mistake. Buspirone is anti-anxiety. Please remember, bupropion is very different from buspirone. Correct. Okay. Now Prabhakar has asked if the patient with SSRI has hypertension. Patient has depression. For depression, he might be taking SSRI such as fluoxetine. Okay, and he also develops hypertension. So can beta blocker be used? Beta blocker can be used or not. SSRI is not specified, so we'll keep it as SSRI. This is the question, and in beta blocker he has asked metoprolol. So tell me, patient is taking SSRI. I am assuming most likely for depression, but maybe for anxiety, and he develops hypertension. Can beta blocker be used? Beta blocker such as metoprolol or not? Now Prabhakar, what I want you to answer, first of all, did this question has SSRI or tricyclic? Did the question that you read had SSRI or tricyclic antidepressant? Can you tell me that? Did the question that you read had SSRI or tricyclic antidepressant? Can you confirm that? SSRI. So now you see SSRI in general. In general, they will inhibit reuptake of serotonin only. They will mainly inhibit reuptake of serotonin. Okay, serotonin has got nothing to do with alpha or beta receptor. So as such, if we take SSRI, beta blockers can be used, metoprolol. But you see they are selective. They are not specific. Okay, selective, not specific. So there can be some amount of inhibition, not very great, but some inhibition of reuptake of Na also. Okay, some amount we can presume for the sake of argument that they are selective, not specific. So we have a situation, assume, where Na has increased in synapse, increase Na has occurred in synapse. Na can act on alpha and beta receptor. Na can act on alpha and beta receptor. You are blocking beta receptor. You are giving beta blocker. So Na will act only on alpha 1. Beta blocker will block beta receptor. Na will act only on alpha 1, and that can increase hypertension. That number one. Secondly, that is number one. Secondly, you see SSRI, as I have told you, SSRI also have CNS side effect, which I told you, insomnia. And if you look at the beta blocker side effect, in CNS, they can also cause sleep disturbances. Third logic, beta blocker CNS side effect, one more CNS side effect is depression. Beta blocker, another side effect is depression. So combination of SSRI and beta blocker is not an advisable combination. Why? There are three reasons for it. Number one, SSRI may in theory increase some level of Na also, and by blocking beta receptor only on blood vessel, we are leaving alpha unopposed. So that may be one increased cause of BP. Number one. Secondly, SSRIs cause sleep disturbances, so does beta blocker. And thirdly, beta blockers worsen depression. So they may have a pharmacodynamic antagonism against SSRI. But in this question, we have assumed, you have not provided, we have assumed that patient was having depression. Okay, maybe SSRI was given for anxiety also, so that we do not know. But if the patient had depression with or without hypertension, with or without SSRI, beta blockers cause depression. So whether for hypertension or any other disease, they are not very safe drug in depression. Okay, so in a depressed individual, overall beta blockers are not very safe drugs. With SSRI, they will cause sleep disturbances, and they may also increase, they may also not be an effective antihypertensive. So there are many reasons because of which beta blocker and SSRI is not an advisable combination. So I hope that answers your question. Next question. Discontinuation of which drugs can result in anxiety and insomnia? Very commonly asked question. Discontinuation of which drugs can result in anxiety and insomnia? I hope everybody would be able to answer this. Repeat question, very commonly asked, and I hope this will be asked in this year's exam also. Discontinuation. So you see, short acting antidepressant, and there are two names that I want you to remember. These names, shortest acting is venlafaxine, which all of you should know is SNRI, and another short acting is paroxetine. Paroxetine, you all know, is SSRI. So these are two short acting antidepressant. They have T half less than 10 hours. So sudden discontinuation, if you sudden stop of these drugs can result in what we call as discontinuation syndrome. Discontinuation syndrome. Discontinuation syndrome mainly is characterized by increase in anxiety. Plus there can be rebound depression also. So venlafaxine or if given paroxetine will be answer to this particular question. Sudden stoppage of short-acting antidepressant. Okay, it will result in anxiety. Now this discontinuation syndrome will be least with long-acting SSRI, long-acting drug, and that you have to remember it will be least with stoppage of fluoxetine. Fluoxetine produces a very long-acting metabolite called norfluoxetine, which has a T-half of more than 50 hours. So it is a very long-acting drug, fluoxetine. So if you stop fluoxetine, discontinuation syndrome will be minimal. It will be minimal or least with fluoxetine because it is long-acting, and it will be maximum with short-acting antidepressant like venlafaxine or paroxetine. The question is asking discontinuation syndrome characterized by many things, but one of the most important symptom is increase in anxiety. Next question, maximum extrapyramidal side effect. Maximum extrapyramidal side effect among atypical antipsychotic is caused by fluoxetine versus amine. Okay, so Prabhakar, I'll come to that query also after this question. Maximum extrapyramidal side effect among atypical antipsychotic is caused by. So what is extrapyramidal side effect? Extrapyramidal side effect number 1 are caused due to D2 receptor blockade. Number 1 point. So D2 blockers cause extrapyramidal side effect. Atypical antipsychotic mainly block 5-HT2A receptor. So why would atypical antipsychotic cause extrapyramidal side effect? So we have to then think of a drug called risperidone. Risperidone is a 5-HT2A blocker, atypical antipsychotic, and in addition it has also got significant D2 blockade. So because of D2 blockade, two side effects will be there. Number 1 is extrapyramidal side effect. That is the answer. And along with extrapyramidal side effect, you see when dopamine is blocked, prolactin goes up. Increase in prolactin. I hope you people are aware and you people remember that from hypothalamus, dopamine is released. It comes to pituitary. Pituitary is having these, dopamine is coming, pituitary is having these D2 receptors. These are D2 receptors on pituitary. So dopamine will act on D2 receptor on pituitary, and what does dopamine do? It decreases prolactin. Okay. So if you give any drug that blocks these D2 receptor, D2 blocker. If you give any drug that is D2 blocker, prolactin level will go up. So among atypical, which causes EPS and rise in prolactin, hyperprolactinemia, answer is risperidone. So among atypical, which causes EPS and hyperprolactinemia, answer is risperidone. Clear? So now EPS is asked in this question, but hyperprolactinemia can also be asked by the same logic. Hyperprolactinemia. So please remember, EPS is coming from a lot of time. So maybe next time examiner is willing to ask hyperprolactinemia. Okay, so which atypical cause hyperprolactinemia? Which atypical causes extrapyramidal side effect? Answer remains same, risperidone. Is that clear? Is that clear? D2 blockade causes EPS and D2 blockade increases prolactin. How? Hypothalamus secretes dopamine. This dot is dopamine. It acts on D2 receptor on pituitary, decreases prolactin. So if you block D2 receptor, prolactin secretion will go up. Hyperprolactinemia. Now, Prabhakar has asked this question of fluoxetine and fluoxamine. So let's look at this. Fluoxetine. As I told you, it is the longest acting SSRI. Longest acting. And then you have fluoxamine. Now fluoxamine is one of the shortest. It's in fact, it is the second shortest acting SSRI. First is paroxetine and then is fluoxamine. So long acting, it will have least discontinuation syndrome. As I told you, least discontinuation syndrome. And short acting, after paroxetine, fluoxamine is the shortest, so it will have high risk of discontinuation syndrome. High discontinuation syndrome. So fluoxamine is shortest, one of the shortest, and fluoxetine is the longest SSRI. Longest SSRI. So I hope you will be able to remember fluoxetine versus fluoxamine. Fluoxetine, which is commonly used, is long acting. Fluoxamine, which is very rarely used, will be short acting. Fluoxamine use, you will particularly find fluoxamine is very effective in cases of obsessive compulsive disorder. So in psychiatry, you will find fluoxamine being commonly used for only OCD. For depression, it is not very commonly used. OCD, fluoxamine is very effective. Next question. Maximum weight gain. Maximum weight gain among atypical antipsychotic is caused by maximum weight gain. Maximum weight gain among atypical antipsychotic is caused by. So maximum EPS amongst atypical I have told you. Now maximum weight gain. Tell me maximum weight gain. So this has become controversial. Okay, this has become controversial. Number one, why there is weight gain? That itself is controversy. Why? Why atypicals cause weight gain? So there can be due to blockade of histaminic receptor or due to blockade of 5-HT2C receptor. Okay. So weight gain is due to blockade of either histaminic or 5-HT2C receptor. Number one. Why there is weight gain? This. Then which one causes maximum? This has been a source of controversy. But nowadays what is widely accepted is that clozapine, if used, will cause more weight gain than olanzapine. So weight gain is more with clozapine as compared to olanzapine. So if clozapine is provided in the option, that will be the answer. But what happens? Clozapine is mostly not provided in the option because it is very rarely used. So if clozapine is given, that will be the answer. If clozapine is not given, then olanzapine will be the answer. So that is again a controversial question, and as per the recent consensus, clozapine if provided will cause more weight gain than olanzapine. That is the order you are going to tick. You are going to tick. Now if I ask you maximum weight gain among antidepressant, okay, not antipsychotic, then which drug will you take? Which drug will you take among antidepressant, not antipsychotic? So if you are asked antidepressant causing too much weight gain, then what will you say? Give me that answer. Give me that answer. Weight gain among antidepressant. Tricyclics may cause, they have antihistaminic, but tricyclics generally do not cause significant weight gain. You have to then remember specific mirtazapine causes too much weight gain. Mirtazapine, please remember, go and read mirtazapine, you will find too much weight gain. Which problem was less with mirtazapine? Mirtazapine में क्या कम था? क्या ये नहीं कर रही थी? Which side effect it was not doing? Which side effect it was not doing? Tell me. Metazapine. थोड़ी देर पहले we did this. Metazapine. Which side effect it was not doing? It was causing least sexual problem, least sexual side effects. Understood? Remember, least sexual problems were there with metazapine. But which problem is more? Sedation and weight gain. So let me just write so you will understand. Least sexual side effect among antidepressant. So I told you two drugs. One is mirtazapine and another I told you to remember bupropion. Now see, now try and appreciate what questions can be asked in this. Now if you look at side effects of these two drugs, then you will find a complete contrast. Both are not causing sexual side effects, so that is good. Mirtazapine causes too much sedation. It causes sedation and weight gain. Obviously, when you sleep throughout the day, you will gain weight. Bupropion is CNS stimulatory, CNS excitatory, so it will not cause sedation. In fact, it can cause anxiety, and if you give too much, it can even cause seizure. So totally different. Okay, totally different from mirtazapine, and it causes all of you, I hope you remember, weight loss. Weight loss. So please try to understand the drugs in totality. Please try to understand drugs in totality. That this question is very common. This question has become very, very common. Least sexual side effects. Okay, this has been repeated many times, so we can think of mirtazapine, bupropion. But then try to compare these two drugs. So mirtazapine is good for a depressive patient who is having difficulty in sleeping. Mirtazapine. And bupropion is good for a depressed patient who is having too much sedation. Who comes to you and says, Dr. Saab, I am having depression and due to depression I am sleeping throughout the day. So give me some CNS stimulant. So that is what I want to highlight, that we have to think what examiner will ask next time. Okay. So that is all we had, and I tried to focus on important points which may be confusing. And that is what I have been doing in the most important pharmacology topic series over the last 3 days, 22nd, 23rd and 24th of February at 6 p.m. Clinical Pharmacology MCQ. 3 different kinds of clinical situations we have taken. And you can, if you have missed, you can watch these sessions on the Let's Crack NEET PG channel. At 8 p.m. on these dates, we have tried to discuss important side effects of drugs. Not just the facts, but I have tried to increase your curiosity of how questions are formed and which point may be the next question to be asked. That is what we had for this session. I hope some of the points that you knew but perhaps did not understand their importance so much, I've been able to highlight those points. And if you like this particular session, please hit the like button. If you have not subscribed to the Let's Crack NEET PG channel, do it right now and hit the bell icon so that you get the timely notification. Use the code Dr. Arpit Agarwal to unlock the free classes if you have first time downloaded an Unacademy app, and use this code for 10% discount if you want to gain a subscription of Unacademy. Okay. So Prabhakar, yes, you're correct. Smoking and depression, bupropion is hypothetically good drug. So that's all from my side in this session. Hope you enjoyed this session. Keep studying, and together with Unacademy, let's crack NEET PG and